Hello, my name's Dylan Hoffman, and this presentation is going to be over internal impingement, sometimes known as posterior impingement of the shoulder. To give you some background and kind of work through this, when we think of shoulder impingement, we most often think of anterior shoulder impingement, specifically whether it's primary or secondary, caused by different sizes or shapes to the acromion or some kind of secondary positioning. This is going to be more posterior. So some tissues involved are going to be the supraspinatus and infraspinatus, and where they meet against the kind of posterior superior glenoid and the glenoid labrum. So right in this area is where we're going to actually see this impingement happening, this internal impingement. Who does it happen to? We're going to see this in overhead athletes. So tennis, baseball, softball, swimming, volleyball. Weightlifting is fairly common, especially if there's bad posture being used, etc. But that doesn't mean that it's only going to be reserved for those kind of repetitive overhead sports. We're also going to see it in other repetitive overhead motions in other populations, such as mechanics, electricians, and other kind of industrial jobs. Right? Anything that requires somebody to have their arms over their head for extended periods of time. And in older populations, like we're going to see with more of these occupations, we're going to see some more kind of secondary conditions associated with the internal impingement that we might not see in a more athletic population. Patients are going to present with deep, achy, and poorly localized pain. There's going to be an insidious onset, probably not a specific moment. Pain may radiate a little bit over the deltoids. You can kind of see this in this picture. It's going to be worse with overhead activities. It's going to be worse with that abduction, extension, external rotation, placing those tissues in that impingement. And there's going to be some pain to palpation posterior to the acromion. Other clinical findings, we may see GERD, or that internal rotation deficiency. They may not have that arc of 180 degrees. It's possible to see some shoulder asymmetry or scapular dyskinesis. That's common anyways in overhead athletes and in throwing athletes, but we may see that particularly pronounced in these patients. There's probably going to be some associated weak scapular retraction and maybe some glenohumeral instability as well. If we're going to do selective tissue testing, it's really not the best testing, but one of them is this posterior or internal shoulder impingement test. If you're looking at it, you may say, oh, that looks a lot like the shoulder instability test. It is. We're going to put it in that abduction, external rotation motion, and we're going to see if that reproduces that pain on the posterior side. So it's important to understand we're looking for pain, and a positive test indicates pain on that posterior side. Again, not the best test, but using this in combination with what you find in the rest of your physical exam could definitely lead you to a diagnosis of internal impingement. But it is important to understand there are some differential diagnoses and a lot of conditions that are going to be associated with this. So when you're doing an evaluation, you need to make sure anytime there's shoulder pain, do a quick screening and rule out cervical radiculopathy. Also go through, you can try and differentiate between is it subacromial impingement, subcoracoid impingement, or is it that internal impingement. A lot of times too, especially in older populations, we may see some rotator cuff tendinopathy associated with this, or we may see some slap lesions also associated with the internal impingement. That's my presentation, and hopefully this is some good knowledge for you to have moving forward and looking at pain on the posterior side of the shoulder, and gives you another differential in your evaluations. Thank you.